Hi, this is Dr. Rick Troutner. I'm the medical director of Bay TMS in Berkeley and San Rafael, California. I'm here to present some of our case studies so that you can understand something about the kinds of patients we've treated and our success. Note that all patients are given pseudonyms in order to protect their privacy, and all patients have given release so that their information may be shared with others. The first patient I call Lynn. She's a 19-year-old woman with major depression and generalized anxiety disorder since the age of 13. She has post-traumatic stress disorder from a sexual assault that occurred 2 years prior to our first visit. She's a college sophomore, majoring in pre-medicine, and she's a musician. All previous treatments had failed, including 4 antidepressants of both SSRI and SNRI classes and 2 augmenting agents. She's had psychotherapy, including cognitive behavioral therapy and DBT, or dialectical behavioral therapy. On evaluation, she presented with severe depression and anxiety. She complained of constant suicidal thinking. She was cutting her arms and thighs and considering jumping in front of a BART train. She described a feeling she called constant dread, an anxious feeling that, quote, something awful is about to happen, unquote. Her PHQ-9 score was 23, which is in the highest range of severity, indicating severe depression. And her Hamilton D was also 23, showing very severe depression. Lynn was felt to be an appropriate candidate for TMS. She began to show improvement in the second week. However, after her 11th treatment, her boyfriend unexpectedly broke up with her. Her scales spiked to even higher scores than they were when she first presented. She lost interest in her life again, began missing classes, and considered stopping TMS. She became acutely suicidal and had to be hospitalized for a day. She then resumed TMS, and her scales began to drop again. School attendance and grades improved. She reported becoming increasingly able to distinguish her sadness about the breakup from depression, which was steadily improving. She resumed playing her guitar and began to enjoy music again. She had a partial recurrence after 8 months and received a booster series of 14 treatments, again reaching remission. She had another partial recurrence 10 months after that and received another booster series of 14. She now remains in remission for greater than 1 year. Lynn wrote a testimonial, which you can read on our website. She described having been depressed her entire adolescent and adult life. She felt that TMS changed her life and even saved her life. She described for the first time feeling that she wanted to be alive and continue living. Case number 2 is someone I call Gail. She's a 44-year-old woman who's been depressed since she was a teenager as well. Her father died at 13. She also has post-traumatic stress disorder secondary to sexual abuse by her brother and verbal abuse by parents. She was hospitalized once after a suicide attempt, and she has a history of cocaine and alcohol use. She also, by the way, had temporomandibular joint surgery, that is a jaw surgery, and has metal implanted in her jaw. However, it is non-ferromagnetic, so it is not a contraindication to TMS. All previous treatments had failed, including more than 13 antidepressants. This included SSRIs, SNRIs, and atypical or antipsychotic agents, which are often used as adjunctive treatments in depression. She's also failed to respond to psychotherapy, including cognitive behavioral therapy and DBT. On evaluation, she was severely depressed and anxious, with some mild obsessive-compulsive disorder symptoms. She was crying frequently and had active suicidal thinking. Her PHQ-9 was 24, in the highest range, and her MADRS was 48, also in the highest range. This shows Gail's treatment course, which was more straightforward than Lynn. She showed no response over the first 2 weeks, just beginning to respond in week 3, and then very robust response by the end, where she reached remission. She had an ending PHQ-9 of 1 and a Hamilton D of 3. On follow-up, she remained euthymic for 10 months, but she had a recurrence, repeated treatment with TMS, and again reached remission. Both of these cases show that even patients who respond well to this treatment don't necessarily maintain their gains indefinitely, although many do. This next case, a patient I call Bill, is someone who has maintained his gains over a long period of time since treatment. He's a 52-year-old male who's had major depression also since his teens. He works as an attorney and a consultant and had been fired from his last job due to depressive symptoms which had interfered with work. He was on disability due to depression at the time of his evaluation. All previous treatments had failed, including more than 8 antidepressants consisting of SSRIs, SNRIs, and atypical agents. He also had failed psychotherapy, both CBT and DBT. On evaluation, he presented with severe depression and anxiety. He described social isolation and feeling it was hard to connect with his 10-year-old daughter. He had severe anhedonia, which is inability to experience pleasure, and amotivation, which is difficulty getting started in activities. He stopped his beloved activities of surfing and biking. He also had panic attacks and was physically agitated. His scores were very high, including a PHQ-9 of 20 and a MADRS of 36, both in the highest range of severity. This shows Bill's treatment course. He began to respond fairly quickly to treatment, dropping significantly by week 3. However, he had a spike in his symptoms in weeks 4 and 5, dropping again in week 6, and finally fully in remission by week 8. As of the last follow-up, more than a year after his treatment, he's remained in full remission. While not every patient has responded as robustly as these 3 patients, these responses are also not rare. These are patients who have failed every other treatment that they've tried and nonetheless have had an excellent response to TMS. When it recurs, we can often achieve remission again with a short booster series rather than a full treatment course. Another way to think about our results is to ask how many people can we help with TMS? If there are 10 patients who come to us saying they are suffering from severe depression and have failed to respond to many other treatments, 3 of them will leave in remission, that is, depression-free. Another 3 will have a full response to treatment, that is, more than 50% symptom relief. An additional 2 will have a partial response to treatment. Less than 2 out of 10 patients will have either no response to treatment or be unable to tolerate the treatment. So who can benefit from TMS? Patients with major depressive disorder, when antidepressants are not providing full symptom relief for depression and anxiety, or if medications are causing unacceptable side effects that limit quality of life. Pregnant or nursing mothers who want to avoid medications may be appropriate for TMS. And finally, patients with medical conditions or other medications that would conflict with antidepressant medication. TMS is now covered by all major insurance plans, and obtaining authorization is usually fairly straightforward. In conclusion, TMS is an effective, safe, and well-tolerated modality for the treatment of major depressive disorder. It may be effective in treatment-refractory or treatment-resistant depression when other treatments have failed. Contraindications are primarily ferromagnetic objects in the head or neck. These could be various implants or retained objects in the head, such as aneurysm clips or metal fragments. These contraindications are very rare, as you might imagine. Side effects are minimal, and generally the treatment is very well tolerated. Beneficial effects are enduring due to something called long-term potentiation, which is a more or less permanent, or at least long-lasting, change in the behavior of neurons in the brain. Thank you for watching. If you would like to receive further information, please don't hesitate to contact us at baytms.com or call us at 510-809-1599.